I'd like to introduce our first speaker, Dr. Gary Nakhuda. He's going to talk to us about the current status of non-invasive pre-implantation genetic testing for aneuploidy. He's an associate clinical professor at the University of British Columbia in Vancouver. Before moving to British Columbia in 2011, he was at Columbia University, where he completed his residency, his fellowship, and he served on faculty for 5 years. He's the founder and co-director of the Olive Fertility Center in Vancouver, and the lead author on the recently published paper and results of the nicest trial, which was recognized as a seminal contribution in fertility and sterility. Gary, if you'd like to share your screen and open your camera, and we look forward to hearing your talk.
Thank you so much, Dr. Trigger, for the kind introduction. I think I'm sharing my screen. Is it visible?
Yes, it's fine.
Okay, very good. Thank you. Thanks again for the kind introduction. I'm so honored to be invited to speak to this esteemed group from all over the world, and I'm a little bit nervous to speak to this large group. I'm just a simple clinician, but I'll be reviewing the current status of niPGT-A, mostly from our clinical perspective, and presenting data from our recent non-selection trial. So just my first conflicts of interest, I'm a co-manager at Sequence 46 and a shareholder in the Fertility Partners. This is the disclaimer that the Thermo Fisher lawyers asked us to display, and I'll get into it. So PGT-A is still controversial for many reasons, but one of the major concerns is the possible harm from the biopsy posed by PGT-A. And this is a divisive issue. There's two camps. Some would say yes, the biopsy is in fact harmless, and there have been at least 2 prospective studies, both from the RMA group, the most recent published in 2021 or so, and it did not demonstrate a difference in the sustained implantation rates between biopsied and non-biopsied blastocysts. On the other hand, there have been several studies, both prospective and retrospective. This is a large one of the review of the SART database of nearly 32,000 cases, which suggested that PGT-A reduced the live birth rates cumulatively, citing the effects of the biopsy as a potential source of the inferior outcomes. And while this may still be a sensitive point of contention, and there's most certainly a range of outcomes dependent on the skill of the embryologist or the lab, I think any logical person can agree that there is at least the potential for risk, given how much skill is required for this delicate procedure. So if asked the question, why are we interested in non-invasive, I would posit that given the choice between an invasive or non-invasive anything, most of us would choose the latter. Specifically for the context of this discussion, non-invasive PGT-A potentially offers to eliminate the risk of the biopsy. It could require less skill from the embryologist, which potentially increases access. And some have said it may lower costs, not so sure about that yet. Maybe it's less labor intensive on the embryology side, but it remains to be seen what happens on the sequencing side. Recently, the ASRM Practice Committee just put out this their statement about routine PGT-A, and it suggests that the routine use of blastocyst biopsy with aneuploidy testing in all infertile patients undergoing IVF cannot be recommended. So this also supports that the innovation of new technologies such as non-invasive PGT-A may help offer better outcomes, hopefully in the future. So there are several approaches that could be considered non-invasive screening tools, including morphology, which we do every day, and time-lapse imaging, which is gaining traction. And this study here was used a mass spec for metabolomics from the blastocele fluid, which is, I think, one of the first published methods as a less invasive analytical method, although one could argue that obtaining blastocele fluid is still not truly invasive. However, the attention has shifted towards cell-free DNA in the spent culture media as the most promising alternative to conventional PGT-A. The first reports documenting the possibility of using cell-free DNA in spent culture media were published in 2016. Musa Shimonki's group used array CGH on trophectoderm and spent culture media on 57 blastocysts. They found detectable DNA in all spent culture media samples eventually, but only 2 passed quality control, but both showed the same copy number in the trophectoderm biopsy and the spent culture media samples. So this was obviously very low efficiency, but it served as a proof of concept that niPGT-A was possible. Several subsequent studies were published in the next few years attempting to validate niPGT-A. The one that I would say was the most impactful was this one authored by Dr. Rakowski and published in the Proceedings of the National Academy of Sciences in 2019. And they had donated embryos that were previously biopsied for PGT-A for clinical purposes. They were thawed and the spent culture media was collected after 24 hours in culture. Then the trophectoderm biopsy and the spent culture media results were compared to the analysis of the whole embryo by NGS. And they reported superior concordance of the spent culture media to the whole embryo relative to the compared to the trophectoderm biopsy. And they concluded that non-invasive PGT-A has the potential to be superior to trophectoderm biopsy for PGT-A while avoiding the trauma associated with TE biopsy. So it seems like every month there is another study that's published seeking to validate niPGT-A by correlating ploidy or chromosome concordance between the spent culture media and the TE or the whole biopsy. And different pre-analytic and analytic techniques have been used to varying degrees of success. This is the most recent study I came across, which is in the September FNS from the IVF Boston collaboration, which used donated day 5 and day 6 blastocysts. They thawed them and they cultured for an additional 8 or 24 hours to determine the optimal timing that allowed successful analysis of the spent culture media. And they reported greater than 90% concordance with the whole embryo analysis. So it seems like we're getting better. And although we're improving, the common challenges encountered by all investigators include maternal contamination, amplification failure, non-interpretable results, and the correlation studies really don't give us a picture of the true clinical value. Furthermore, we're still not clear where the cell-free DNA is actually coming from in the spent culture media. If you rule out exogenous contamination and maternal contamination, the thought is that this DNA is being released via apoptosis. It may be coming from either the trophectoderm or the ICM or both, and it appears to happen in both euploid and aneuploid cells. So all these studies have helped to establish the foundation for niPGT-A, but there are still significant limitations to the body of literature. For example, many of the studies use methods that are not consistent with routine embryology practices, thus may not be really clinically practical. Also, it's important to highlight that benchmarking to trophectoderm biopsy assumes that the trophectoderm biopsy is accurate and deterministic, when we all know that that, in fact, is not always the case. Furthermore, in studies where the embryos have been selected by niPGT-A, but they were also biopsied, really negates the advantage of a truly non-invasive procedure because they were biopsied. And also, perhaps most importantly, if only putatively euploid embryos are transferred, we are never really scrutinizing the false positive rate. So an unbiased study must transfer embryos blinded to the analytical results. So what is a non-selection study? This is what we needed for a non-invasive PGT-A. And even though the term has crept our way into the vernacular, critics would argue that this is not a standard epidemiological term, but it refers to a blinded prospective observational cohort design, where the embryos are selected by routine criteria, but the analysis of the archive test sample is only released after the clinical results are known. So this allows us to calculate the clinically relevant predictive values by comparing the actual outcome to the outcome that would have been predicted if the test sample had been used for embryo selection. The goal is to ensure that the error rate is as close to possible, ideally less than 5% to avoid harm to patients, and ensure that competent embryos are not being routinely discarded. We can attribute the term non-selection to the prolific RMA group. Their most recent non-selection study investigated the positive predictive value of whole chromosome aneuploidy detected with conventional PGT-A, and they stated that the primary goal was to predict the failure to deliver. And they reported a positive predictive value of 100% for whole chromosome aneuploidies. However, they also distinguished abnormal copy number variants other than whole chromosome aneuploidy that they coined as uncertain reproductive potential. And these, in fact, showed poor positive predictive value with sustained implantation rates of as high as 41%. So it's important just to define what predictive value means for aneuploidy screening. So a true positive is an abnormal NGS profile associated with a non-viable outcome, so failed implantation, spontaneous miscarriage, or clinical aneuploidy. And a false positive is an abnormal result associated with a viable outcome. For an abnormal copy number, the positive predictive value is what we're interested in. A true negative is a normal NGS profile associated with a viable outcome. A false negative is a normal NGS profile associated with a non-viable outcome. And for a normal copy number, the negative predictive value is what we are interested in. Positive predictive value and negative predictive value always depend on the prevalence of the condition in the population, or you can consider that the pretest probability. In a low prevalence population, where the condition is relatively rare, there's actually a higher risk of false positives. Thus, a low prevalence population is a greater challenge to the positive predictive value. And predictive values are more relevant than sensitivity and specificity when people are being screened, whereas sensitivity and specificity are the best indices for analytic or pre-clinical studies. But we're focusing here on the predictive values. So we endeavored to emulate the so-called non-selection study design to investigate the predictive values of non-invasive PGT-A. Our results were published in FNS in July of this year, and we were honored that it was deemed a seminal contribution. My co-authors are the excellent team at Sequence 46, Sally Rodriguez, Sophia Tormasi, and the very talented Catherine Welch, who happens to be on this call. The trial was nicknamed the NICESS trial, which stands for the Non-Invasive Chromosomal Screening for Embryo Selection trial. So the objectives, the primary objective was to investigate the positive predictive value of whole chromosome aneuploidy. In other words, does aneuploidy detected by niPGT-A accurately predict non-viability? We would have to transfer the embryos blinded to the results, and this would reveal the false positive rate. The predictive values of abnormal copy numbers other than whole chromosomes were also of interest. So we would characterize those as well. The secondary objectives were to investigate the QC parameters associated with the NGS profiles with niPGT-A, and just to add a larger descriptive data set to the literature, although these embryos were not connected to a clinical outcome. So we have quite a bit of data in our paper that I invite you all to read, but I'll stick to the primary results for the rest of this lecture. The inclusion criteria were patients under 35 at the time of retrieval who had an indication for ICSI and a plan for a deferred frozen embryo transfer of a single embryo. Patients were excluded, if they had recurrent implantation failure, recurrent pregnancy loss, required a trifecta biopsy, or had a plan to transfer more than one embryo. So why do we focus on the young patients? So again, given the lower prevalence, I'll go back. Given the lower prevalence of aneuploidy relative to the older age groups, with a relatively higher risk of false positives, we could expect the younger patients to be the best challenge for positive predictive value. This was intended as a pilot study, so sample size was not determined by a power calculation, we targeted a sample size of 120 patients based on an expectation of approximately a 50 to 55% live birth rate per single embryo transfer in this group. And we estimated that if the false positive rate was 10%, we should have seen about 6 to 7 sustained implantations that would have been incorrectly classified as non-viable. So essentially 6 to 7 false positives were expected. Our clinical methods were relatively straightforward. In the laboratory performed a culture media change on day 3, at which point the embryos were moved to individual 30 microliter drops. Now, that's a relatively large drop size compared to other studies, but we wanted to keep it as consistent with standard embryology practices as possible. The blastocysts were vitrified. No hatching was performed before vitrification. Spent culture media was collected in PCR tubes, de-identified and shipped to the reference lab. When the patients returned, the embryos were selected based on standard grading criteria, and the results were unmasked after the clinical results manifested. So after a failed implantation, a miscarriage, or after 13 weeks of a viable pregnancy. And standard prenatal testing was offered to all patients. We used a validated PGS platform. Apparently, I'm not supposed to say the name, but it's all in the paper. The technique involved the whole genome amplification with 150 to 2,000 reads per sample. And the QC metric of the median absolute pairwise difference less than 3 was the threshold to pass QC. The primary NGS interpretations were either failed QC if the MAPD was above 0.3, no copy number variant detected if the copy number fell between 1.5 to 2.5 for all chromosomes, or an abnormal copy number variant if it was less than 1.5 or greater than 2.5 for any chromosome. We then also stratified the abnormal copy number variants to subcategories. The primary interest was whole chromosome, which we called if it was 3 or less whole chromosome aneuploidies. And then uncertain reproductive potential, or ERP, would be other abnormalities like segmentals, combined whole and segmental, or chaotic profiles, which were more than 3 chromosomal abnormalities. We also stratified the copy number variants, the abnormal copy number variants, to either uniform, if there was either less than 1.2 or greater than 2.8 copies, or intermediate, which we would, synonymous with mosaic for trophectoderm biopsy, if the copy number was between 1.2 to 1.5 or between 2.5 to 2.8. The sex chromosome interpretations were a little tricky. We did see all the typical sex chromosome aneuploidies, but we did see some patterns that were not typically seen with conventional PGT-A, like non-integer ratios of X to Y. So when this occurred, we classified according to the autosome number, and then we called it sex undetermined. We analyzed all the typical clinical outcomes, but again, the primary outcome of interest was non-viability, which included implantation failure, miscarriage, or a clinical aneuploidy. Now, live birth rate obviously is usually the primary outcome of interest in our field, but because positive predictive value of abnormal results was being scrutinized, we were actually more interested in non-viability. And to the results, so of 120 single embryo transfers, when unmasked, these were the niPGT-A results. 9 or 7.5% failed QC. In 75 or 62.5% of the total, there was no CNV detected. And an abnormal CNV was detected in 30% or 36. Of these, 18 were whole chromosome aneuploidies, and the remaining 18 were a combination of the uncertain reproductive profiles. And then of the whole chromosome aneuploidies, 5 of them were of the intermediate copy number extent, and the 13 were uniform copy number variations. So if we look at the clinical outcomes stratified by NGS interpretation, overall 64 of the 120, or 53.3%, resulted in a sustained implantation. We actually followed these to live birth, but for the paper they're labeled sustained implantation. For the primary categories, for failed QCs, 6 out of 9 actually were sustained, so 66.7%. When no copy number was detected, 57.3% were sustained. And collectively for all of the abnormal copy number variants, the sustained implantation rate was 41%, which is still pretty high. However, when stratified, if we looked at the whole chromosome aneuploidies, there was only one sustained implantation out of 18. The other uncertain reproductive potentials had a very good sustained implantation rate, 14 out of the 18 actually. So to the primary outcome of interest, this is where we calculated the positive predictive values and calculated the relative risk relative to embryos with no CNV detected. So again, in aggregate, if you look at all the abnormal copy number variants, the positive predictive value was 58%. The relative risk compared to no copy number variant was 1.37. This is not statistically significant. However, if we look at the whole chromosome aneuploidies, the PPV was 94%, and the relative risk was 2.21. This was highly significant. The others, again, were not significant. When the extent of the CMV was substratified, so for whole chromosome aneuploidies, we broke it down into either the uniform or the intermediate. If you look at the uniforms, there were 0 out of 13 that were sustained, or 100% positive predictive value. Out of the intermediates, which can be considered analogous with mosaics, there was 1 that was sustained, which gives it an 80% positive predictive value. There's actually no difference when we compared the positive predictive values statistically, but obviously there was 1 live birth. And this was a trisomy 20 when we unmasked the results. We were able to there's another interesting case of a patient who appeared to have a viable pregnancy, but when the niPGT-A result was unmasked, it revealed a trisomy 22, which we at first thought was a false positive, but the patient pursued amniocentesis for suspicious anatomic findings. And then the amniocentesis actually revealed a partial tetrasomy 22. So even while it wasn't the exact structural aneuploidy, niPGT-A did in fact flag the abnormal copy number of the correct chromosome. Now, the sex chromosome ratios were significantly skewed female. In samples overall, and also in samples with no copy number variant detected, there was predominance of XXs, and the difference in proportions was significant. However, if you look at the any of the abnormal CNVs, we can combine those. There's actually no difference in the sex chromosome ratios, which is interesting. And then we were able to confirm the sex predicted by niPGT-A clinically to either birth outcomes, NIPT, or amnio. And 54 with informative sex chromosomes and clinical results were available for comparison. Overall, 74.1% were consistent. All 14 that were misdiagnosed were clinically XY, but called XX by niPGT-A. But conversely, when XY was identified by NGS, male sex was always confirmed clinically. We also then performed a post hoc analysis. The purpose of aneuploidy screening is to accurately identify non-viable embryos, but also to enrich the remaining pool to improve the probability of selecting a viable embryo. So if we deselected all of the whole chromosome aneuploidies, we would have been left with 102 transfers as opposed to 120. This would have resulted in a sustained implantation rate of about 62% compared to 53%. So about 9% higher, which we would say is pretty important, but this was not clinically significant. And if we deselected only the uniform whole chromosome aneuploidies, so kept the intermediates in the pool, the sustained implantation rate would have been 59%, nearly 60% compared to 53%. Again, a relatively important difference for our patients, but not clinically significant. Although we think this is probably just type 2 error, we needed a bigger sample size. So ours was the first blinded study to report the clinically verified prognostic accuracy of CNV abnormalities detected with non-invasive PGT-A. For the whole chromosome aneuploidies, we had a very good positive predictive value of 94.4%, which was statistically significant. And there was a high relative risk of 2.21 compared to embryos with no aneuploidy detected, no copy number variant detected. However, the other copy number variants of uncertain reproductive value had very poor positive predictive value. And if we had deselected these embryos in real life, we would have discarded a lot of viable embryos. So this just emphasizes what I think we all already know by this point: all abnormal NGS profiles are not alike. Just a word on the negative predictive value of normal niPGT-A results. A negative predictive value is always expected to be lower than positive predictive value because embryos may fail to implant for numerous reasons, undetectable by any single testing method. In our group, the negative predictive value, which is synonymous with sustained implantation rate, was 57%, which most of us would say was pretty good. And even though it's not a direct comparison, if you look at the STAR trial, the sustained implantation rate was 49%. And if we look at our own internal patients who've had conventional PGT-A, the sustained implantation is about 55%. So at the very least, with a non-invasive method, the negative predictive value was as good as conventional PGT-A. So the biggest challenge from our study was the ability to consistently obtain informative niPGT-A results. If we combine the undetermined or uncertain results, out of the 120 patients, there are a total of 27 between the failed QC and the uncertain reproductive potential. It's 22.5%. It's probably a little bit too high for clinical use. We definitely encountered maternal contamination. It's interesting that the sex ratios were equal in samples with abnormalities, but unequal in other cases. The 46XY and non-invasive PGT-A results always were clinically confirmed, so 100% accuracy when we see that. But the overrepresentation of 46XX alludes to maternal contamination. And this is something we need to be careful about, particularly as we get to older patients where there's a higher risk of aneuploidy. We might be masking those abnormal results. So next steps, we're planning another trial. We're going to focus on an older cohort. And again, the risk of false negatives will be higher. We suspect false positive rates should be even lower, but it's going to be crucial to have informative results. We've already have some plans to refine our techniques, both pre-analytically and analytically. And this is just a speculative question, but I've always been curious, and I've spoken to others in the field who have the same hypothesis that maybe abnormal copy number variants, different types of copy number variants are indicative of disparate outcomes. So in other words, is it possible that when you see a segmental aneuploidy in the spent culture media, is it actually a predictor of sustained implantation rather than of failure? So we don't have any kind of neat biological explanation for this, but it's interesting. So the goals of non-invasive PGT-A, in my opinion, are to obviate the need for trophectoderm biopsy for aneuploidy screening, and I'm willing to bet we will get there soon. This was summarized by Cooper and Viotti recently in reference to mosaic results in conventional PGT-A, but it rings true for non-invasive PGT-A too, and it's always been designed to be a screening test to reduce time to baby, not to improve cumulative live birth. We can't make embryos any better than they are, but we certainly shouldn't be reducing cumulative live birth. And PGT-A should be considered a ranking tool to help pick the embryo more likely to result in a healthy live birth and less likely to end in a bad outcome. But the binary classification of NGS results is simplistic and inaccurate. So I think we are gonna have to consider a multi-omics approach. I think non-invasive PGT-A with a high positive predictive value can help deprioritize the abnormal embryos with the whole chromosome aneuploidies, and we'll probably need another technique, which could be AI imaging, time-lapse, what have you, to select the remaining embryos that have with a negative predictive value. So pick the best embryos. We're just going to have to use a couple different techniques. And I would like to just conclude by again thanking the amazing team at Sequence 46, Sophia, Sally, and Catherine, my incredible embryology team here at Olive. We couldn't have done the work without them. And thank you all for listening. I hope to collaborate with all of you. We are planning that second trial. So if anybody is interested in participating, please get in touch and we will get details out as soon as we have them.